Our next speaker is a serial offender at this meeting. He's just a consummate educator, especially clinical educator. David Spach has a unique ability to take often complex medical issues, digest them, and then give them back out in a way that's totally understandable. And you'll see that in his talk today when he covers latent TB coverage with antiretroviral and drug interactions. His slides are fabulous. And this ability to communicate has garnered him many awards in teaching. He leads a large number of programs, including the Mountain, or the AETC, the Mountain West, is that right? Yeah, and has done that for years and has this education to Alaska and other surrounding states of Washington. He's at the University of Washington, works out of Seattle. If there's any national resource on HIV education, David is at the heart of it. And you'll notice at this meeting, he's been here from the beginning, even though his talk is today, because we value his input, his participation on the panels, and it's just a joy to continue to work with you, David. Welcome.
Mike, thanks for that very generous introduction. I also want to acknowledge Dr. Cheever real quick. I have been involved in the AETCs and Ryan White for more than 25 years, and I personally, and I just want to say, I think every single person who's in this room has benefited from her decades of leadership, not years or days or weeks, but decades of leadership. So I just personally want to thank her. What I'd like to do in this talk today is I'm going to talk about some of the more sort of recent updates that may actually change your practice, and that hopefully maybe coming out of this meeting you'll do something different. I do not have any financial disclosures, but I will mention one thing. When I talk about vaccines, I'm going to use trade names. There are not generic names designated to vaccines. So the only way I think that I can communicate effectively which vaccine I'm talking about is to use the trade name. And that's the only reason I'm doing it, is because there are no actual generic names. So three major objectives, or four major objectives. The first, and Mike mentioned this, I'm going to go over really in the clinic how you think about when people have latent TB and they need to be on antiretrovirals, and kind of a practical strategy to approach that. The next I'm going to do is kind of hot off the press, what's the newest in hepatitis B vaccine recommendations, just as actually of a week ago guidelines were updated. And then to talk a little bit about statin recommendations, and this came up in the panel yesterday, but I'm going to dive a little bit deeper into this, try to give you a little bit of the rationale for really why these recommendations came out. And the last, just mention something very briefly, which has come up in the clinic a lot recently, is how do you manage community-acquired pneumonia? And I think in our clinic, I noticed there was a lot of misunderstanding about what the guidelines say, and I thought I would just review that as well. Okay, so let me start off with latent TB. And this is very confusing, and I want to, as Mike said, try to explain this in a way that you feel like when you walk out of here, if you're in the clinic, you could actually do this, and that's the goal. Many of you may already feel very comfortable with this, but I will say this can be very confusing. So the first thing that I think is really confusing is you hear all these numbers, 3HP, 4R, blah, 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 and people see all these recommendations, and they wonder what all these numbers and letters mean, and there is a logic to them, but let me run through it very briefly. The number 3 or 4 is just based on the number of months. The letters are designated on a letter of the drug, but that's where it breaks down a little bit, and it's a confusing letter designation. So here's where these letters come from. So the H for when we say 3HP, the H for isoniazid comes from the INH. That's where H comes from. Rifapentine, 3HP, the P comes from the P in rifapentine. Go figure that, okay? And then the R is nice and easy and straightforward, rifampin. So if you've wondered where these letters come from, that's how they're designated, and if you can remember this, then it'll make it much easier when you're hearing people toss out these terms like this, 3HP, 3HR, this is what it means. 3HP is 3 months of INH and rifapentine. 3HR is INH and rifampin. And I think it's really good just to start there so we're all on the same page when we start tossing around these letters and numbers, because this is the way I hear everybody talking in the clinic, and this is the way we look at the guidelines and these recommendations, but many people get confused what these letters actually mean. Okay, so where are we with the recommendations? These were updated in September. And for those of you that follow the HH guidelines really carefully, the two things to note are that they were just recently updated, but the TB recommendations get updated in two places. They get updated in the OI guidelines, but they also get updated in the antiretroviral co-infection section. And they're not always in sync, so sometimes one is a little bit ahead of each other. So I'm going to actually give you sort of where both of them are in an updated fashion. So where are we now with latent TB recommendation? We have moved to short course 3 months as the preferred modality for treating latent TB. When I trained, everybody got INH. 9 months or 12 months, everybody got it. There were no short course latent TB offerings that we had. So now the preferred is a 3 months, which actually really simplifies things dramatically. But note, when you're giving 3 months of 3 HP, that is a weekly regimen. This could be done with a person coming to a clinic once a week and getting this administered. That is a very realistic possibility if you were concerned about their ability to take a daily medication. 3HR is daily rifampin and INH. And just to remind everybody, anytime you're using INH, you do need to add in pyridoxine. I think most people are very familiar with that. So I'm not going to really say that again, but that is part of any INH-based regimen. So alternative regimens, you have 3 good choices: 6 months or 9 months of INH. And again, when we trained, everybody got 12 months. This got moved down to 9 months. And now the guidelines give you the choice 6 months or 9 months based on data that 6 months and 9 months appears to be equivalent for people with HIV. Rifampin, just straight up rifampin, can be given for a 4-month regimen. But again, this is somewhat difficult because of drug interactions that I'm going to get into in just a minute. And then last, we have our ultra short course, 1 month, which wouldn't surprise me if we, in the future, see more data on this and maybe this becomes very, very attractive. Right now, it's an alternative, but this is isoniazid and daily rifampicin. So when you're talking about rifampicin, you got to distinguish the 3-month course is weekly, the 1-month course, the 3-month course is weekly, the 1-month course you have to give daily rifampicin, and the drug interaction issues are different if you're giving it daily. Okay. So this is sort of visually what this looks like in terms of your options. And the blue is what's preferred. And you can kind of march down to you have options all the way going from a 1-month to a 9-month course. But the sweet spot in terms of the recommendations right now are what's in blue, which is the 3HP and the 3HR. So I am going to focus on that a little bit more. Now, the tricky part with this is that many people are on, as we saw yesterday, BIC-TAF FTC is what most people are starting. There are some problems with drug interactions, and so it's hard to get this to both work out the way we want to have them on the regimen we want and to have them on this short course TB regimen we want. That's what I'm going to navigate through. This is a table that I'm only going to briefly touch on that is the full table that's updated in the guidelines. It includes the drug interactions on the TB drug on the left, in the middle, the backbone option, which now is great because essentially we can use TAF-FTC, TD-FTC with latent TB, and that's different than it used to be. The anchor drug is where it's problematic, and this table includes things like efavirenz and raltegravir and so forth, which we don't see much in clinical practice use anymore. So I'm going to move to the next table, which is sort of the clinician's practical table. And this is really the key drug interactions for you to know if you're prescribing latent TB for someone on antiretroviral. So the good news is the top line in green, if you're giving INH, you're home free in terms of drug interactions. There are essentially no major drug interactions with INH. So if you ever have a concern about drug interactions, you can always fall back on, I can give this person 6 months or 9 months of INH. That's a really nice thing to remember. You can always fall back on INH. So you don't have to think at all about drug interactions with that. If you're giving weekly rifampicin, the good news now is the anchor drug, you can use dolutegravir. So you can use daily dolutegravir. Now, just to clarify, this is meant for people who are not failing antiretroviral therapy and are on twice-a-day dolutegravir because they have integrase resistance. These are people with suppressed HIV RNA levels, that everything is stable, or you're starting antiretroviral therapy. The rifampicin daily is different than the rifampicin weekly. So notice, when you get rifapentine daily, it acts almost like rifampin in terms of the level of drug interactions. So here's the tricky one. If you're giving rifapentine daily, you have to double the dolutegravir to twice a day. But the key thing to remember that's the hardest and trickiest part is you've got to continue the dolutegravir for 14 days after you finish that 1-month course. This is the place where people would probably goof it. And I would goof it if I didn't know this and hadn't looked at it now a million times. Because this is tricky. We're not used to doing this, that you've got to continue that double dose dolutegravir for 14 days after you finish the daily INH rifapentine, okay? And so the last is rifampin. And rifampin, you've got to increase the dolutegravir for twice a day, but you don't have to do that little extra tail extension at the end. Okay, now let's actually get into in the clinic. Put it in the clinic, what do you do from a realistic standpoint? And this comes up in our clinic, and I'm approaching it this way because this is the way I've been trying to work with clinicians in the clinic to how to do this. So you have a patient who's taken, the most common antiretroviral regimen, Bic/Taf/FTC. They're diagnosed with latent TB. They have persistent, undetectable HIV RNA levels. So how do you manage this situation? Okay, so here's your options. You can think about the antiretroviral therapy as your priority, or you can think about the latent TB as your priority. So that's really your decision making. What's going to be the priority based on shared decision making with your patient? Okay, so if you see the person and they say, look, I'm on my Bic/Taf/FTC, I love this, I am not going to stop it no matter what, I'm not going to change it, then fine. You have one option. You can put them on INH. You can give them 6 months or 9 months of INH, and that's fine, totally acceptable. INH is an alternative, not because it doesn't work, it's only because it probably has a lower completion rate because it takes 6 months to get the person through. So there's a really good option there. If, however, you want to go with the priority of the 3 months, a person says, I really want to just get this TB stuff over with, then you need to change the Bic/Tegravir. You cannot use Bic/Taf/FTC with these short course regimens. So now you just change them to dolutegravir/Taf/FTC, pretty minor change for while you give the 3-month course, and then you just, if you want to change them back, great, or you can keep them on that. And then the same thing basically if you're going to give 3HR. You do the same thing, but now if you're giving the rifampin, the 3HR, you've got to actually increase the dolutegravir to twice a day. So the little bit easier is the weekly INH rifapentine. Okay, now, what about if you want to use the ultra short course? You're really, really worried about this person getting in the latent TB, and you really want to give them the ultra short course. Again, now if you're giving the dolutegravir, this is the one where you've got to double the dolutegravir and keep it going for an extra 14 days. Okay? So that's the tricky one. The 1-month ultra short course, you've got to continue it on for an extra 14 days. Now the last thing is, what if you're in the clinic and you've got a situation where a person has latent TB, but they don't have good virologic control? So here you're really stuck because you can't really rely on sort of all of these drug interactions and manage this. So my recommendation in this situation, if you've got somebody and you've got to be shifting there, you may need to use a boosted PI, or you may need to use the NNRTI, or you don't know what you're going to need in the next couple of months. In that case, I think you really need to plan on putting that person on INH so you can do anything you want with their antiretrovirals. That's how I would approach that. Okay, now, let me shift gears now and talk a little bit about hepatitis B. And this came up in the panel yesterday, but let me try and start off kind of at the beginning and just to remind you that we have 3 different types of hepatitis B vaccines. To the far left are the old tried and true single antigen vaccines. These are your Combavax and Endurex-B. These are the ones you've been using for years and years and years. The one in the middle is Heplisav-B. And again, what makes Heplisav-B so unique is not that it has a lot of hepatitis B surface antigen in it. It's that adjuvant that's an oligonucleotide that activates toll-like receptors in immune cells and really revs up a great immune response to this vaccine. That's why Heplisav-B is unique. The one on the far right, which is a triple antigen vaccine, so instead of just having the surface antigen that's the large surface antigen, it has all 3 of the different types of surface antigen, the large, the medium, and the small. This was felt to maybe provide a broader immune response because you're exposing the immune system to 3 different types of surface antigens. That vaccine is called PreHevbrio. For all of you, and I just found this out from our workshop yesterday, this vaccine is essentially pulled off the market as of yesterday. So it is in the guidelines. I would not recommend using this because you are not going to be able to get follow-up doses. So if any of you are really carefully looking at the guidelines, which I'm going to show you in a minute, this was pulled off the market yesterday, and apparently they're even sort of saying like they're dumping out the vials. The company went bankrupt, so this is not going to be an option for your patients. And it's in the ACIP recommendations. This is a brand new recommendation. Okay, now, what's the preferred hepatitis B vaccine? This is new as of a week ago. When I presented this conference last week, I showed some data on HEPLISAV-B and people who were with HIV who are getting this as their initial vaccine. It looked better than anything we had before. I said, I anticipate this will probably be what we're going to be using as our preferred vaccine. And sure enough, the guidelines came out this last week, and it was great to see this. HEPLISAV-B has moved from a recommended to a preferred vaccine for people with HIV. But notice the wording in here, not subtle, says the alternatives are only supposed to be used if HEPLISAV-B is unavailable. So this is a pretty strong recommendation to move to HEPLISAV-B, and it is based on two things. You get a better immune response, and it is much easier to complete a vaccine series in people who get 2 doses 4 weeks apart. Much easier. So this is really preferred. Now, we still have our alternatives with Engerix-B Recombavax. Just one subtle point as well, for those of you that really are following this, if you're using Engerix and Recombavax, you're supposed to be using double dose of it. Some places don't have access to HEPLISAV-B. So if you're using Recombavax or Engerix-B, you're supposed to be using a double dose. One subtle point, and I think this has not been clarified in the guidelines, if you are using Twinrix, what is in Twinrix is Engerix-B. The amount of it is single dose. So if you're giving people Twinrix, don't be fooled. You are giving them single dose hepatitis B immunization, which is not what's recommended. So this is kind of a discongruent recommendation. But trust me on this, you look up in the prescribing information on Engerix-B, look it up in Twinrix. The amount in Twinrix is not double dose hepatitis B vaccines. That's a subtle difference that makes me not want to advise using Twinrix. That's, even though it's in the guidelines as an alternative. Now, how did we get to this point? Again, why this is such a preferred vaccine. This is called the Beehive study, and without belaboring this is to just show you the antibody responses after people get 2 doses, 1 month apart, dose 1 and 2 on those numbers there. The number of people with seroprotective antibodies is above 90%. The one point I would make, you get a continued climb for several months. So everybody says do a hepatitis B antibody titer 1 month after you finish. If you look at this data, you can actually say you're probably even better off waiting 2 months. There's not really a downside to that, to checking it. So I personally think see them on that visit, give them their initial dose, and at their follow-up 3-month visit, that's a great time when you can check their follow-up titer. I don't think you have to do it 4 weeks after. I think 8 weeks after, totally fine. Okay, now, what should you do for people who don't respond to the hepatitis B vaccine series? Brand new recommendations from the guidelines, just came out. As you might anticipate, what do they recommend? They say, well, if you didn't respond to Engerix and Recombavax-B, now you should give these people HEPLISAV-B. That is what's recommended in the guidance. They don't actually even go through revaccinating with the old vaccines. They just list this as what you're supposed to do. They also say, since these people may be immunologically more challenged to respond to hepatitis B vaccine, you can certainly give them a 3rd dose if they do not respond. So again, give them their first 2 doses, check 4 to 8 weeks after that. They haven't responded, get them scheduled to get a 3rd dose at 6 months later. So that's where we are with the guidelines. There are data on this, not yet been published, and I'll show you in a second. So what about if somebody got HEPLISAV-B and didn't respond? That's a hard one. If they didn't respond to this, then they recommend in this case is that you could give it to them as a 3rd dose if they only got 2 doses, or you could give PreHevbrio, which is the vaccine that I just told you is now off the market. So please note, that, and as I was saying this to Mike a minute ago, this is maybe the shortest guideline in, it's going to be guideline out, a matter of probably 2 days, because this guideline came out, they thought this was probably great, and then sure enough, the company pulls the plug on this. So this, just to be careful, is not something I would recommend, since you really need to be able to complete the whole series with the vaccine, and PreHevbrio is now going to be off the market. Okay, so honestly, in this situation, there's not a lot of great options, and you could redo the HEPLISAV-B. You could maybe try, indirect recombinant vax B, double dose, 3 doses. We don't know what to do. The only other thing, and I mentioned this in our workshop yesterday, for those of you who work any with employee health or personally did not respond to your standard hepatitis B immunization as a healthcare worker, there are data now with HEPLISAV-B in healthcare workers that looked fantastic. With 2 doses, I think the response was around 85%. So this is a really nice thing to know for those of you who did not respond to hepatitis B, or you work with other fellow healthcare workers who did not respond to the standard hepatitis B immunization. Okay, now how did we get to this recommendation now that we actually are recommending it for people who've had a poor response? This is the second phase of the Beehive study that was presented last spring at CROI, but has not yet been published, probably, hopefully, pretty soon. And this is basically just looking at HEPLISAV-B, which is the HEB, CPG, that's the abbreviations for it. So, and they compared it with Endurex-B, and without going into a lot of details, I will tell you, the one thing about this study is a lot of people in this study had pretty good CD4 counts. So the median was 638. So this is a little hardier immunologic population than I think we frequently see in the clinic. But with that said, what they looked at was 2 doses or 3 doses of HEPLISAV-B for people who didn't respond to previous immunization, or Endurex-B giving 3 doses of that. And it was standard dose of Endurex-B, not double dose. And this is what they found. So the good news is, if you take people who didn't respond, you give them HEPLISAV-B, 2 doses is on the left, 3 doses in the middle, and you can see you can have a very good chance, especially if they have a higher CD4 count, that they are going to respond to this as a sort of a second chance after they didn't respond to initial hepatitis B immunization. So in our clinic, I would say what we've probably seeing in the predominant number of clinicians in our clinic is people getting HEPLISAV-B up front. For non-responders, we're typically giving 2 doses of HEPLISAV-B, waiting 4 to 8 weeks, checking a titer. If they're not okay, then going ahead and giving them a 3rd dose. And I think I'm not going to go into that right now. We can question and answer if people still have questions about isolated core. One point about HEPLISAV-B, and this is relevant in my mind to isolated core. The brown are people that get really high serologic responses, greater than 100, which again, I said, that is the target with isolated core. And you can see with 2 and 3 doses of HEPLISAV-B, especially 3 doses, you get people, very high percentage of people that get to that target antibody above 100. So this gives you not only a good immune response, but a very high titer immune response with HEPLISAV-B. Okay, now let me shift to hepatitis D, which many of you may not have heard a lot about. And this is a virus that is what we call a satellite virus. It is codependent on hepatitis B. You do not get hepatitis D unless you have hepatitis B. You can get co-infected at the same time, or you can get sequentially infected, but if you're sequentially infected, it's B first, then D. Because as you see from this picture, hepatitis B, the surface antibodies are shown there on the outer surface of the virus. This is actually what is used in the vaccines. If you look at hepatitis D on the right, it is a smaller, it's about half or 2/3 the size of hepatitis D. It is a smaller sort of surface version of hepatitis B, but notice the inside of it has a different structure and different antigens. These are called the large hepatitis D antigen, the small hepatitis D antigen, and hepatitis D it's an RNA virus. So you do need to have hepatitis B to get hepatitis D. And they are different. Hepatitis B is a DNA virus. Hepatitis D is an RNA virus. So different conceptual viruses, but again, the whole surface of hepatitis D, if you look at it, comes from B. So you can't have circulating hepatitis D unless somebody has had hepatitis B infection. Okay, here's a question for you. Based on the most recent HHS guidelines for people with HIV and hepatitis B, when is routine screening for hepatitis D recommended for people with HIV? It is not recommended A, it's recommended in all persons with HIV, or C, it's recommended for all persons with HIV and hepatitis B co-infection. What do you think? And Mike, do I need to activate to push? Okay. Just to show it? Okay, thanks you. Okay, excellent. Okay, so you understand conceptually. So this is a brand new recommendation that came out less than a couple months ago. And I've never screened routinely for hepatitis D. I'm not sure what we're going to do with that information, but it is what's in the guidelines. And I do want to illustrate where we are with this, which is I think we're light years behind being able to know what to do to treat hepatitis D compared to our other viral hepatitis viruses. Okay, so this is the guidelines. Because hepatitis B and D co-infection is associated with serious liver complications, experts recommend screening for hep D in people with co-infection. Okay, so that's a new formal recommendation. The question is, why? How often are you going to find it? People with HIV, about 10% have hepatitis B co-infection. Of those co-infected people, about 4% are going to have D. If you find D from an antibody, you need to go on and do an RNA test. But about 40% of people will have it. So why are we worried about it? People with hepatitis B can get cirrhosis. We all know that. You look at the progression with co-infection with HIV, it's accelerated. You look at triple infection, HIV, hepatitis B, and D, it's markedly accelerated. So that's the reason we're worried about it. And really at this point, we don't have great treatments for D. That's the problem. So screening, yes, that's useful. Just treating B does not get rid of D because we really don't eradicate hepatitis B. We're just suppressing it. So treatment with hepatitis B alone isn't going to work. PEG interferon, it works okay, but not very well. There's a bulevirtide, which is not FDA approved in the US. That and PEG interferon look to be the best. But even then, after a couple years of sub-Q treatments, you only have about a 40 or 50%. So, why are we so, I think, interested in statins and HIV? As Mike mentioned yesterday, there's this concern that people with HIV have this hyped up inflammatory response, and the real interest in using statins with people with low cardiovascular risk was because it was believed to have some anti-inflammatory effects. So what do we know from all the data with this increased inflammatory is that people with HIV have an increased risk of myocardial infarction, stroke, and cancer from this believed to be this sort of chronic inflammatory state. So it was logical to think about using statins. So now let me just go through very quickly what the guidelines now say, and we talked about this yesterday, so I'll briefly go through it. But basically we have our moderate intensity and high intensity statins. The initial therapy that is recommended routinely now is these moderate intensity statins, which is pitavastatin, rosuvastatin, and atorvastatin. If you're going to use high intensity, you really only have the choice of rosuvastatin and atorvastatin for people with HIV. So what did the new guidelines say? What they actually said is pretty much anybody with HIV you can consider giving a statin to. The A recommendation was anybody with an ASCVD score greater than 5%. So 5 to 20%. The recommendation then is an A recommendation to give them a medium potency statin. That is a pretty powerful recommendation. That's a lot of people in the clinic. Anybody even who's less than 5%, there's a C recommendation that you could use a medium intensity statin and nobody should be, saying that's a bad thing to do. That's where I think the sort of the art of it and the clinical judgment, we're seeing a lot of flexibility with that. People who are under age 40, these recommendations do not hold. This is for people 40 to 75 years of age. So what about the outliers? What about somebody who has a ASCVD score that's really high, above 20%? Well, they're not in the guidelines, but they point this out. Those individuals need high-intensity statin. So your high-dose rosuvastatin, high-dose atorvastatin. Somebody 20 to 75 has got a really high LDL, greater than 190. They need a high-intensity statin as well, too. And what about people with diabetes? That's a more negotiated where you would probably look at them for either medium or high intensity statin. So these guidelines really give you a framework that pretty much allow for statin prescribing for anybody with HIV. Again, thinking about this not only for lipid lowering, but really as this inflammatory effect. This is based on the REPRIEVE study that Mike mentioned yesterday, which without going through a lot of it in detail, I did want to emphasize, this is a large randomized trial where they entered people with low cardiovascular risk scores. And this is the graph that shows you sort of the range of their cardiovascular risk scores. 0 to 2.5, 2.5 to 5, 5 to 7. That was the majority of the people who entered this study had an AS-CVD score less than 7.5. And what did they find? As we talked about yesterday and Mike showed, there was about a 35% reduction in major cardiovascular risk events. Not minor, but major cardiovascular risk events. And this really occurred across the spectrum, except the one subgroup that didn't do well was a 2.5 to 5%, but even the very low, they had a significant benefit if they got pitavastatin versus placebo. And again, pitavastatin was the medium potency statin that they used in this trial. A lot of people are always concerned about side effects, which I think are very manageable because if a person has it and they don't want to keep taking the statin, you can always stop them. But this was diabetes that occurred, slightly higher rate than placebo, muscle-related, slightly higher, but not a huge difference. So that's where we are with those recommendations. And the final case I want to present is one last audience response question. So 38-year-old with HIV is taking BIC-TAF-FTC with consistently suppressed HIV RNA levels. He's diagnosed with community-acquired pneumonia. The plan is to provide outpatient oral treatment. So most recent CD4 count, 430, not neutropenic, no pre-existing lung disease. What do you want to give this person with HIV for community-acquired pneumonia? Doxycycline, amoxiclav plus azithro, or doxycycline plus moxifloxacin? Okay. All right, fabulous. Okay, so this was about 50% of people chose the correct answer, amoxiclav plus azithro. I just want to emphasize this is actually in the guidelines now for management of community-acquired pneumonia. Many people don't think of this, of an OI, and don't know this is in the OI guidelines, but the rationale for using something in addition to azithromycin is that in the US, the number of pneumococcal isolates that are susceptible to erythromycin, which is basically a surrogate for saying resistant to azithromycin, is high, and that only 69% are susceptible for these pneumococcal strains. So because of that, we now recommend using a beta-lactam like amoxiclav or amoxicillin along with it. So that is all I had, and I just want to thank you again all for being here and for listening. Thank you.
Great. I have a cynical first question, and that is, in latent TB treatment, where is the H in isoniazide?
Well, it's the INH. It's not in the word, it's in the abbreviation. That's what's so confusing.
That's what I'm saying.
Oh, no, it is. No, it's very, that is why this is so confusing. And that's why I actually spelled it out and put it on the slides, because many people have a really hard time following this. And I am not sure if this came from WHO designation or CDC or where it came from. I know it's not HHS language. This came from previous language. But it is what it is.
It came from a spelling bee. The other thing is, in your last case, I was looking for the answer moxifloxacin or levofloxacin alone.
Yeah.
Which would have been acceptable.
Yes,
right?
yes,
okay.
yes.
So you don't necessarily have to use two drugs.
Thank you, yes. And I didn't go into that, and actually you can also use tetracycline with amoxiclav as well. Doxycycline would be what most people would use because it's BID, yes.
Right. I'm going to go around like this. Let's start here. Yep.
Thank you, Dr. Spach. I appreciate your presentation. I have a question about latent TB infection. How you interpret those quantiferon? If you don't know well the patient, if the patient has been in other clinics, and seems that quantiferon tends to remain positive. So that's what I want your expertise. Maybe I don't know much about it, but how you take that and you're going to jump into treating or not a patient with a positive quantiferon?
Can you repeat that again, just because my hearing?
I didn't hear it either.
Can you repeat it again? Sorry, my hearing is not the best. And
okay.
It's actually hard to hear up here.
Yeah.
So the interpretation of the positive quantiferon test.
Yep.
So how, like if you don't know well the patient, if the patient even is unsure that in the past has received a treatment for it, so what is it?
Yeah, you're asking if a person has a positive quantiferon and you are not sure they've been treated before, I think you're stuck with those individuals unless you can document they've had prior treatment either for TB or latent TB. You are stuck. And that is one of the dilemmas everybody should understand, is that with TB, once a person trips and they have a positive quantiferon or positive tuberculin skin test, that is frequently going to remain positive for life. and you've lost your barometer to really know. And so people can get reinfected with tuberculosis, so you just have to presume unless you can document. Now, if somebody's previously been treated and they come in with symptomatic pulmonary infections, then you diagnose it clinically. But I'm assuming you're talking about an asymptomatic person. I think you're stuck and you would have to give them latent TB treatment.
Okay, in the back. Speak up.
Hey, David, thank you for that. I have a question, the difference in the mechanism with the RIF drug interactions with bictegravir compared to dolutegravir. Do we know that, or is it just we don't know it and that's why it's not one that you can still use if you have them on the rifabutin or the rifampin?
With dolutegravir?
No, with
Bictegravir.
bictegravir.
Oh, so
we just don't know.
bictegravir, they've looked at this, and the drug levels are unacceptably low. And so this is actually based on data, and so I don't think that's likely to change soon. The place where there's the most controversy is with tenofovir alafenamide. This was on essentially do not use recommendation for a pretty significant period of time. Recently, the guidelines are allowing it. I didn't mention this, but it is recommended if somebody's on TAF, they should get more, it says just continue virologic monitoring. So, but most of these short courses are pretty short, so I think, they maybe get one extra viral load check. The guidelines don't say. The issue with TAF is that the serum levels with it do go down, but when they looked at it in a more involved way with intracellular levels of tenofovir, they were actually at good levels, and so that's why the guidelines have shifted to allow TAF as an an option.
Awesome.
So a comment and a question. So one, I think the amoxiclav plus the azithro actually is quite apropos because we're seeing crazy levels of mycoplasma in kids right now, and so could potentially have been part of what the issue was with the patient. My question was about cabotegravir and drug interactions in terms of the...
So cabotegravir?
Yeah.
So cabotegravir is unlikely because when we're using cabotegravir, we're also using it with rilpivirine, and there are major problems with rilpivirine, drug interactions with rifampin and rifapentine. Efavirenz is the only NNRTI that you can use in this setting, but again, we're using very little efavirenz, and essentially all of the boosted PIs are out when using rifampin or rifabutin or rifapentine. So really with TB management, the boosted PIs are really a problem, and rilpivirine is the problem with that. Cabotegravir, I don't know how intensively that's been studied, but I know with just that combination. Now for PrEP, that's an interesting. So if you're thinking about, I do not know the answer to that, but I know in the guidelines they did not mention cabotegravir. Raltegravir is acceptable. So I'd have to see if they've studied that. I don't know. It's a great question, but I know cabrylpivirine is out, but for PrEP, if somebody needed it, I don't know. Interesting question. Yeah. I don't know if they've even thought about addressing it, but I love it.
Cab is very similar to dolutegravir.
Yeah, it should be okay.
Yeah, but we don't know. Yes.
My question is about if people fail 2 rounds of the Hep B vaccination, is there any evidence for people with HIV in using the hepatitis B immune globulin to get them to the threshold of protection if they're still at risk for Hep B?
I can't hear it. Can you?
I couldn't hear it well either.
Can you repeat it again? Or
sure.
Yeah, and I would suggest if some people, so my hearing isn't the best, so if you want to write down the questions, that's going to be even better. I'm sorry I can't hear you.
No worries, yeah. So my question is about people who fail 2 rounds of Hep B vaccination. Is there any evidence for people with HIV in using the hepatitis B immune globulin to help them achieve immunization?
Hepatitis B immune globulin?
Yeah.
Yeah, so the hepatitis B immune globulin. Oh, okay. Great, thanks. This is a combo you want to? You can know better. Okay. So in terms of hepatitis B immune globulin, so we would, hepatitis B immune globulin really only should be used in people after an exposure. So I'm presuming you're talking about people who've never responded to hepatitis B vaccine. So for post-exposure prophylaxis, a person who has clearly not responded to hepatitis B vaccine, they are supposed to get hepatitis B immune globulin and then get another dose a month later. If somebody you just don't know their titer and you're uncertain, they usually typically get a dose of hepatitis B immune globulin and then just get a booster dose of vaccine 1 month later. But people who are known non-responders to vaccines, the only time we use hepatitis B immune globulin is to give it and then give it repeated again a month later. Right. Maybe you can read a few.
Yeah, so I'm sorry, I just think because actually both David and I both have hearing deficits, I think we might just go to cards. I'm sorry, if that's okay, and come down. One helpful audience member just reminded me that INH is more than isoniazid. It's isonicotinic acid hydrazine.
I love it. Yeah. There we go.
go.
There's your H. Thank you.
We're here all night.
We've got a chemist in the audience. Thank you.
So yeah, there had to be a reason. It just wasn't made up. So I'm going to just read off some here. Can there be a disruption in rifampin therapy and for it to be complete? In other words, if you complete 1 month but go all the way. Yeah.
So this is, it's a lot like, when people miss the number of days after they miss their latent syphilis dose shots and where there's a lot of controversy. So there are not clear guidelines for how long people can basically be off of the therapy and have to restart it. Typically, most people would say after 7 days that you would probably restart it. And I haven't seen formal recommendations. If anybody in the audience knows that there's been guidance that's been issued, please let us know. But I know in the OI guidelines, I have not seen them address that. I don't know if you've ever heard that. Yeah.
So are there specific recommendations for Hep B boosting doses if the patient has waning immunity?
Yes. Okay. So there's different scenarios, and it's interesting. Laura and I were sort of just talking about this again, how much this has changed. So there's different ways that people have waning immunity. So a lot of people have been vaccinated with older hepatitis B vaccines or vaccinated as a child, probably responded great, and then over the years their titer went down. So for example, that's a typical thing for healthcare workers when they're going in, and typically what you do is you give them one shot and look to see what sort of titer they get after that. If they get what we call an anamnestic response, which means not to forget, they remember and they get a very nice boost up in their titer, then they are considered not to need any further immunizations. People with HIV, we recommend checking their Hep B serology, triple screen, surface antigen, surface antibody, core antibody for everybody entering care. So essentially, we're saying even if we think you got a vaccine as a child, we're going to check your antibody titer. So we should be doing this. I will say, this came up, Kim mentioned this yesterday, we've seen several people who were immunized years ago with HIV and then years later actually had a response and had hepatitis B. So we haven't seen any new guidance for this, but I personally think it's reasonable in your clients who've had 15, 20 years ago, especially if you're thinking about switching them to a 2-drug regimen, recheck all of their hepatitis B serologies. But if you know they responded before, you'd probably just give them 1 dose, look for the booster response, and if it's great, then you would stop with that.
Yeah. So this is one about INH, 6 months, 9 months. It seems kind of awkward to say choose. So briefly, what are the data?
So the data are that it appears right now there's more data with 9 months, but the 6-month data does look good. So I think depending on sort of your comfort level and the patients, I personally have really switched over to using 6 months when we use INH because I think that data is solid. I think the bigger issue is, and it's kind of back to the point about the rifampin, is can you get that person to sort of really reliably take those meds and finish that course? And so I think that's where the highest priority is.
Right. And then hepatitis D, I think you said it well, but why is there a recommendation to test for something for which you can't do anything about except wring your hands and worry?
So that's a great point, and when we had a previous conversation about this, Mike brought this up, and that is really part of the point of me presenting this, is for you to know this is a recommendation, but know it's very limited what you can do with this information now. The one reason I would say is that it is very important to know that these people probably have very accelerated liver progression. So if you were to diagnose it, these are individuals I would probably be more often checking in to see, if they've not already got cirrhosis, maybe rechecking, doing some type of a liver assessment, fibrosis score or FibroScan in 5 years or something, because they are more likely to progress. The second thing is, I think knowing that the hepatitis D is out there in about 4% of those co-infected individuals, more aggressive vaccination and making sure we're preventing hepatitis B infection, because every person that you prevent hepatitis B, you're automatically preventing them from getting hepatitis D. Point well taken, though. I think we don't have a lot we can do at this point.
Can you talk a little bit about rifapentine daily versus weekly in terms of tolerability?
Yeah, so the tolerability is better with the daily than the weekly, but in general, I would say the success rate, and at least in terms of, I think some clinics experience, and it's been variable, some clinics have really initiated a person coming in once a week and doing the weekly, and I think just because they're getting a higher dose at once, they tend to have more GI side effects, but overall completion rate has been really good with that because it's really basically you can set up directly observed therapy. Can't really, none of the TB public health systems are set up to do latent TB daily, directly observed, but something like this could be done in a Ryan White clinic, I think. Person just drop in, get their dose once a week.
So we're out of time, but I do want to get this one out there. We used to vaccinate a lot of people for A as well as B. We used Twinrix. Now we're going to use Hepaslav. Do you just add in the hepatitis A at the same time?
Correct. And so you do the hepatitis A, then you're going to give them a Hepaslav. You do that at the same time, give them the Hepaslav B 1 month later, and then at 6 months, give them their second dose of the hepatitis A. Unfortunately, there's not a, unless a person's traveling, that's the schedule we would recommend.
Great. Thanks, David.
Okay, thanks.
Yep. Let's get this guy's phone. Yeah. There was a comment nicely brought to us on the phone, but that rifampin is not indicated with cabotegravir. So that's, yeah, that would make sense.